Hello and good morning, everybody. Dr. Vasquez here, coming to you live on the 1st of March, 2025. Happens to be my birthday month, and what I had said recently is that I would go over the examination questions from the dysbiosis course. So this course on dysbiosis, I think, was about 20 hours of continuing medical education, and with that course, I had to include an exam at the end of it. So it's only 10 questions. And even though, of course, my intention was to make those questions very difficult, I think that the advice that I received from the Joint Accreditation Organization was to make them not so difficult so that people could just get their credits and pass. So that's unfortunate. You know, we call it CME, we call it continuing medical education, but it's kind of just sitting there and getting your credits. A lot of times the exercises or the events have exams with them, but the exams are really simple. So the bar for continuing medical education is mostly just showing up and sitting down. So we're going through the syllabus. I haven't looked at this syllabus in several years because I didn't have a need to. The program was completed and was reasonably successful for what it was supposed to be. So I'll go through the questions right now, and let's see. I would like for that screen to be a little bigger, so I'm going to turn my screen sideways, and I'll have to adjust the video later. So like I said, I'm going to go through these questions. I'm also going to show you the thought process behind the questions and the answers. So I'm a really good test taker, as you might have guessed from going through, so many, whatever it was, 16 years of college. So I'm a really good test taker. Writing exams from the perspective of a professor is quite difficult, actually, because a good exam question, at the graduate level looks for nuance, but you also want to have clarity and distinction between a right answer and a wrong answer. And sometimes that's a very fine area to work in. You're aiming for a detailed reply in a multiple choice question, but obviously the exam has to be fair as well, So, like I said, the good thing about not having looked at these questions in several years is that now I can look at them maybe more objectively or more critically, and certainly with another 8 years of experience in looking at research and thinking about things. I'm kind of surprised that my work has, especially the graphics, but the graphics and the level of detail has continued to increase over the last couple of years. It's not like I, went to school, graduated, studied, developed my ideas, and then they just kind of stayed static. A lot of my ideas are continuing to advance. So as we look at these questions, we'll be able to see, what might be different now compared to what I thought about and the way that I thought about it so many years ago. And like I said, I'll show you what I think is the correct answer, and I'll show you why I think it's the correct answer. And if my question is not a good question, then I'll tell you it's not a good question. I don't need to defend this. I'm going to try to use this as an exercise not only in deepening and understanding in an active way about microbiome and dysbiosis, but also, kind of the thought strategy behind all of this to see if that makes the exercise more valuable. What else? I haven't had breakfast yet, so that's my disclaimer. I have had 4 cups of strong Texas-sized coffee, but I haven't had I haven't had any food at all, just coffee. And so if I flake out a little bit at some point, that's my excuse. Over-caffeinated and under-sugared. So let's look at the first question. A young child is brought to your office for treatment of eczema. Atopic dermatitis, which is another phrase for eczema, is commonly known as eczema and is generally treated with anti-inflammatory agents. Like if you go to most, I guess even dermatologists, it's really an embarrassment. But if you go to most dermatologists or most family medicine doctors, they're going to use steroids and anti-inflammatory drugs. Anti-inflammatory agents, steroid cream, histamines, immunosuppressants, immunomodulators, and moisturizers. Yep, that's the recipe for eczema in most medical practices. It's really an embarrassment. Patients with atopic dermatitis show increased production of IgE and histamine following exposure to which of the following microbes and excuse me, and eradication of this microbe via the use of antimicrobials such as cephalexin and bleach baths results in clinical alleviation. This is a really easy question. So, as I've said before, and I'm not trying to be too sarcastic about this, but like everybody thinks they're an expert until they get tested by an expert, So, again, in summary, this is a really easy question. It's basically just asking you what is the microbial basis for eczema. And this is a slam dunk. There's no question about this. There's no gray room. So this is a well-written question. It's a little, the sentence stem is a little longer than it needs to be. But, I could have just said, what's the microbe associated with atopic dermatitis? And that would have been sufficient. But it's a gloriously long question stem. And the answer is super clear. So let me go to my highlighter and I'll just highlight the correct answer. I think that we will use purple for the correct answer. So your options are Candida albicans, probably a contributing factor in some cases, but it's not causative. Saccharomyces boulardii, Streptococcus pyogenes, Pseudomonas aeruginosa, Staphylococcus aureus, Klebsiella pneumoniae, and E. coli. So, Candida albicans maybe is in the periphery, but it's not the major player. Saccharomyces boulardii is obviously the wrong answer. Streptococcus pyogenes, no. Pseudomonas aeruginosa, no. Klebsiella pneumoniae, no. E. coli maybe plays a distant role. But the most obvious and correct answer is clearly Staphylococcus aureus. No question about it. It's pretty much black and white. And the research on that's been solid for like 20 years or at least 15 years. So, I guarantee you that most family medicine doctors don't know that. Or they might have read about it, but then they don't know what to do with it. And dermatologists probably the same. So, yeah, a lot of people with eczema, atopic dermatitis have an allergy to their own skin bacteria. And in this case, we're talking about Staphylococcus aureus, gram-positive microbe. And if you get rid of the Staphylococcus aureus, their eczema goes into remission. And obviously, you can do other things. You can treat them with antibiotics. You can treat them with povidone iodine. You can treat them with bleach baths. And obviously, you can use nutrition to support immune function to help promote tolerance, but also to help promote clearance of the microbe. That's been my basic strategy for, I don't know how long, 20 years, something like that. So that's a good question with a good answer. It's very clear. It's black and white. You either got it or you didn't. Let's look at the next one. Your patient developed an autoimmune disorder following an infection. Amino acid homology produces molecular mimicry. So you can see that I wrote these question stems with kind of a teaching component within them. Amino acid homology produces molecular mimicry, which is necessary for the resultant immune cross-reactivity. That's basic immunology. Cross-reactivity between sequences in Acinetobacter and Pseudomonas aeruginosa is most relevant for patients with which of the following? Acinetobacter and Pseudomonas aeruginosa. So again, this is pretty black and white. Could you find a few exceptions? Yeah, you may be able to find some exceptions. But in terms of looking at the research and then correlating that with disease outcome, the answer on this question is very clear. Your options are, and again, so basically we're trying to connect. If you look at this from a test-taking strategy standpoint, what is the autoimmune disease associated with a microbe, with the mechanism being molecular mimicry, which is basically the same as cross-reactivity, and specific to Acinetobacter and Pseudomonas aeruginosa. So here's another question, a well-written question. The answer is very clear. Definitely not chronic fatigue syndrome, not fibromyalgia, not ankylosing spondylitis. So ankylosing spondylitis would be a reasonable, that's a good option, because ankylosing spondylitis clearly has, it's considered an autoimmune disease, clearly has a microbial trigger that functions through cross-reactivity and molecular mimicry, but it's not Acinetobacter and Pseudomonas aeruginosa. So that would be a great answer for somebody, like for a student who didn't really read the notes or really didn't study. They might pick ankylosing spondylitis. Autoimmune, microbial triggered, molecular mimicry, cross-reactivity, but it's not Acinetobacter and Pseudomonas. Atopic dermatitis, no. Psoriasis, no. That's another microbe-triggered autoimmune disease, but it's not to those particular bacteria. Antiphospholipid antibody syndrome, it's kind of attractive. Oops, sorry, but not that attractive. So that leaves us with neuritis, or multiple sclerosis would be a really good answer as well. But Acinetobacter and Pseudomonas aeruginosa, especially Pseudomonas aeruginosa. Pseudomonas aeruginosa produces a protein that cross-reacts with myelin basic protein, and that's obviously one of the antigens in neuropathy and multiple sclerosis. So that's the correct answer. Let's go to number 3. Your patient presents with persistent nasal congestion and crusting. So if you know the research, then you already know the answer. Your patient presents with persistent nasal congestion and crusting and had a recent event of hemoptosis, that's coughing up blood. ANCA-associated vasculitis, formerly Wegener's granulomatosis, also called now it's called granulomatosis with polyangiitis, ANCA, associated vasculitis, is a life-threatening autoimmune vasculitic disease, which is most commonly associated with colonization dysbiosis of which of the following microbes? That's the real question. Which produces an antigenic acid phosphatase enzyme, which haptenizes to vascular endothelial cells to create an immunogenic neoantigen. So this is another question that's black and white. Super clear. Like you either know it or you don't, but it's well established, and this is a good question. So basically, again, this used to be called Wegener's granulomatosis. Wegener was a Nazi physician, so that's why he lost his title, so to speak, and that's why they changed the name of this condition, again, previously known as Wegener's granulomatosis. Now it's called granulomatosis with polyangiitis. Yeah, like I said, super clear. It's obviously not, well, it's obvious to me, but the answer is not Candida albicans, Saccharomyces boulardii, Streptococcus, Pseudomonas, Klebsiella, or E. coli. The answer is Staphylococcus aureus. So, obviously you remember from a few minutes ago, I talked about Staphylococcus aureus being a trigger for eczema or atopic dermatitis. That's correct. In other people, it triggers Wegener's granulomatosis. The laboratory or wet bench evidence for that's very obvious because of the antigenic acid phosphatase, which kind of has an electrostatic charge with it, and it binds onto endothelial cells, just like I said in the question stem. And so that's why these patients respond to antimicrobial therapy, for example, to get rid of the Staphylococcus aureus. So a lot of them have a positive clinical response to that. Question number 4, a radiologist asks you about the mechanism of action and clinical benefit of probiotics. Probiotic foods and prebiotic nutritional supplements have gained wide, popular, and professional use and acceptance over the past several years, well, 20 years by now. Which of the following are expected to be increased by administration of probiotic bacteria? That's the real question. So you take probiotics, and what do you get from it? Do you get more superantigens and LPS and IL-10? Do you get more bacterial DNA, hydrogen sulfide, and P-cresol? Do you get more butyrate, P-cresol, and tyramine? Do you get more superantigens and P-cresol? Do you get more butyrate, IL-10, and T regulatory cells? Or do you get more Th17 and IL-6? So this is a good question. Basically, this question is simply asking, do you understand how probiotics function? So what would be the postbiotic product of a prebiotic or a probiotic? And then what would be the physiologic effect of that? So that's a reasonable question. And the answer is very obvious. I mean, if you understand basic immunology and microbiology and a little bit of nutrition, then you already know the answer. So a lot of times, again, I've taken thousands of exams through chiropractic college, chiropractic board exams, getting licensed in 3 different states. Texas was the hardest for sure because it was the most backwards. Going through naturopathic medical school, getting licensed again in 2 different states, going through medical school, taking all those medical board exams, and then some other like certifying exams for obstetrics and pediatric care and all this kind of stuff. So I've taken a lot of exams, so I'm a really good strategist in terms of taking exams. And for this question, for example, you don't even have to know anything necessarily about prebiotics if you just understand. I mean, you could answer this question from a prebiotic nutritional standpoint, or you can simply answer it from the immunology standpoint. I mean, even if you don't know anything about probiotics or prebiotics or postbiotics, then you could still answer this question correctly because all of the question options are pro-inflammatory and pathological, except for one. And the only good answer here that you would actually want is this choice right here, butyrate, Treg, and IL-10. So basically, and generally speaking, the way that probiotics function is to create more butyrate. I mean, that's the fatty acid that you want mostly from probiotics. You don't really want propionic acid. You don't really want acetate. The main one that you want is butyrate. That helps your body produce more T regulatory cells. Those T regulatory cells function partly, but largely through the production of interleukin-10. So this is obviously the correct answer. I'll go through the other answers. So when I take an exam, I mean, for medical exams, for example, I think for most medical board exams, you only have like 72 seconds per question, or it might even be less than that. But for some reason, I think it was 72 seconds. So, I'm talking my way through this, but in a real medical exam, I mean, you're hitting it hard and fast. So let me just go through the thought process that I would use. So the first question that you have to ask yourself when you're reading a question in an exam is, what is the question? Sometimes the question stems have helpful information, but a lot of times they have distractors. And sometimes they're asking for shades of gray. So the question could ask you, what's the best answer? So not simply what is a correct answer. They could all be correct answers. But the question might be asking you, what's the most affordable answer? Or what's the safest option? Or even the reverse, I guess. They could be asking you, what's the most dangerous or least indicated option? Or the question could be, your patient has this disease, but they're financially restrained. So are you going to use, rifaximin in somebody who's financially restrained and can't afford a $700 antibiotic? Obviously, that wouldn't be the answer. So, again, my approach to answering examination questions is the first question is you have to figure out what are they asking. And in this case, it's pretty straightforward. It's just asking, what is the mechanism through which probiotics provide their benefit? And it's usually by reducing inflammation. So superantigens are pro-inflammatory, LPS is pro-inflammatory, IL-10 is anti-inflammatory, but the other answers are incorrect. So that makes the entire answer incorrect. Bacterial DNA is pro-inflammatory. P-cresol is, associated with autism. That's irrelevant to this question. Hydrogen sulfide can be kind of pro-inflammatory, kind of anti-inflammatory. So it's not really a clear option, and that makes it the wrong option. Butyrate is good. P-cresol is and tyramine is So that's not an attractive selection among the options here. Superantigens, again, pro-inflammatory. You don't want them. P-cresol, irrelevant. That makes that the wrong answer. Th17 cells are pro-inflammatory. IL-6, interleukin 6 is obviously pro-inflammatory. So that's, again, the wrong answer. So the correct answer is butyrate, interleukin 10, and T regulatory cells. Let's go to question number 5. And I think maybe what I'll do is I'll answer question number 5. I'll divide this into 2 different videos, and that'll give me a chance to go eat breakfast. But let's look at this. So far these are good questions with good, clear answers, pretty black and white. Let's look at question number 5 here. Your patient has suffered from a debilitating illness for many years. That doesn't tell us anything except that it's chronic and severe. Which of the following conditions is most noteworthy for being characterized by small intestine bacterial overgrowth, mitochondrial impairment, neuroinflammation, or brain inflammation? More specifically, it's not like a peripheral neuritis. And insufficiency of L-tryptophan coenzyme Q10, also known as ubiquinone. So I did see this as I was preparing and saving this document so I could go through it. So let's look at what is the question actually asking. So this is a chronic illness. Patient's in pretty bad shape. The defining characteristics of this disease are small intestine bacterial overgrowth, mitochondrial impairment, brain inflammation, I put neuroinflammation, and deficiency of tryptophan and CoQ10. So remember what I said a minute ago. The question is asking which of the following conditions is most associated with those characteristics. Not simply associated, but where is the association most strong? So obviously I'm foreshadowing the fact that this question has a little bit of gray zone, which also means that I could have written a better question, or better answers, I should say. The question's good. I don't completely enjoy the options that I provided as far as question answers. So let's start from the bottom. Antiphospholipid antibody syndrome is chronic, severe, life-threatening, but it's not associated with those other characteristics, so this is not the correct answer. Psoriasis can certainly be debilitating, and it's chronic, and associated with small intestine bacterial overgrowth, but it doesn't have the other characteristics, so that's not the correct answer. Atopic dermatitis isn't even close. Neuritis, or some type of autoimmune peripheral neuropathy, could be severe, it could be associated with microbes, but it's not a strong answer. Ankylosing spondylitis, small intestine bacterial overgrowth, yes, but it doesn't have the other characteristics, so that's not it. So that leaves us with chronic fatigue syndrome and fibromyalgia. The better of the answers, and let's say that I had explained this in the course materials, the better of the 2 answers here is fibromyalgia. Debilitating chronic SIBO, mitochondrial dysfunction, neuroinflammation, deficiencies of L-tryptophan, and CoQ10, perfect. Fibromyalgia is the perfect answer. The problem is chronic fatigue syndrome isn't a bad answer, it's just not the best answer. If I had given this exam to students, a percentage of the class would have complained that, well, chronic fatigue syndrome is so similar to fibromyalgia that the distinction there isn't really clear. And that's correct. But again, at a doctorate level, I think that the distinction that I'm looking for still stands, because I asked for what is the most associated, or what is the most noteworthy. I didn't say what's close or what's reasonable. I said what's the best answer here. And that still points in the direction of fibromyalgia, even though a strong argument could be made for chronic fatigue syndrome. So if I were to rewrite this question, I would put a different answer there. Whatever, any other condition, autism would be not bad, but fibromyalgia is the best answer. So how about if we call it good for now? We went through 5 of the 10 questions, and I'll come back later in a few minutes or an hour or whatever. I'll go get some exercise and eat and drink more water, and then I'll come back and do the rest of the questions. So I hope you're all doing well. Sorry if you missed me in February, but I was really busy doing a lot of things. February was an incredible month for me, doing things that I don't want to do, but doing those things successfully, otherwise known as eating the frog. But I'll talk more about that later. I think later today. So I'll do part 2 of this video, and then either today or tomorrow I'm going to talk about sales techniques. I know that's a weird topic for me to touch on, but I actually have studied on that topic for. I mean, I've been familiar with some concepts, since I was like 16 years old, because that's when I started studying certain things. Maybe I was 14, but maybe let's say 16. Certainly by the time I was 16, I had become familiar with certain ideas in business and sales, and I had to revisit some of those ideas over the past month, because I had to deal with people in sales who were screwing up their jobs. And so their screw up was obvious, but then I had to go back myself and study, like, what's the break in the chain here? Like, what's not working here? And so I'll share that with you later today or tomorrow. But anyway, I'm going to go get breakfast or brunch, as it might be, and then I'll get back and do the rest of these questions. Okay, until then, take care. Bye.
I'm an old soul, got a funky sound. Gonna sing a song, turn the world around. I whoop that ass, you know I got the moves. Spank that ass, I'm gonna make you move. I ain't no player, I'm just here to shake. No time for heartbreak. I'm the one who brings the rhythm to the night. I keep you dancing.